Thank you very much, Carmine, for an outstanding presentation with lots of questions, in fact, and opening and new questions opened by your new findings. So if you agree, we're going to move on to the next speaker, and we ask our online colleagues to keep their questions and write them down. So don't forget to write them down. And I'm very, very happy to ask my co-chair this morning to come to the microphone, Brenda Penninx, that you've already heard several times this morning, is going to describe her important results for stratification of depression with regards to immunometabolism. So Brenda Penninx is epidemiologist. She's professor and chair of psychiatry at the Department of Psychiatry in University of Amsterdam, and she's the PI of a very important cohort project, which is the NESDA cohort that you all know and all read about a lot in several outstanding publications, and which is a follow-up cohort of patients with depression and anxiety, which is one of the biggest in Europe and probably above. So thank you very, very much for this presentation. We're just waiting for technical problems.
Great. I think the technical problems are solved. So really nice. It's a little bit strange for me to stand here after Carmine's talk because our titles are slightly different, but there is quite some overlap. But I do think that validation is key in our field. And I actually do think it's sometimes good to hear stories tagging about the same processes from different angles. So I think that I take that as my challenge. I really, in the last 20 years, my research has been zooming in on depression. And just to take you one step back to why we are in this field, looking at biological-based processes relevant for depression, I think this is where we come from. And this is currently, unfortunately, still the state of the art. So depression is prevalent. It's one of the major burden of or diseases with huge burden of disease. Also, according to the WHO definitions, this is in the top 10 and actually in the top 2, depending on what outcome you're looking at. And I think we all know that. But I think what we may not always realize that this has been not changing over the last 30 years, despite the fact that if you just look in modernized countries, you know, there are more and more people requiring and getting care for mental health and also for depression. If you look at the number of people using antidepressants in lots of European countries, this has doubled or even tripled or even more increased over the last 20 to 30 years. However, if you look at the impact of depression over time, and that's the lower figure that we published in a recent overview paper in Lancet, the impact of depression has been quite stable. And this is in contrast to quite a lot of conditions where they have been able to reduce the impact of disease over time. And I think this is really what we are facing. We're not really doing things yet to really change the curve and the impact that we can have and should have on mental health of our general population. So I think what I ask is why is this impact of depression so large? I think it's important to realize a few key features. And I think we also learned that over time more and more. Obviously, there is the high prevalence of depression. But I really think that our original indication of depression was this is an episodic condition. We treat an episode and after that, the person is recovered. I think, unfortunately, I think there are now quite a lot of long-term course studies that show that the chronicity of depression is huge. And actually the chronicity is it's really the major finding that we see if we follow people long-term over time. It's really not the exception, but it's more the rule that people very often have quite chronic trajectories, of course. Also, it's a condition that starts early in life, and in combination with this chronicity, it can really affect people for very major stages of life and also in their work productive life. So obviously it also has lots of impact on functioning at the societal level. And I think it's another indication that I sometimes really think is not always the right direction, is that mental health has really drifted apart from somatic health. And I think this is really unfortunate, because I think if we really look at what is going on in lots of mental patients, is that there is a very strong interaction with somatic health. And that interaction is really relevant and is really something that needs to be incorporated in treatments. And I think this is also something that is not happening at a very large scale. And I think we are losing opportunities that we would have if we really look more closer at the integration between mental and somatic health. So underlying problems that really lead to these issues are really the heterogeneity in etiology, symptomatology, and course in depression. And we're not incorporating that at all right now in medical treatments. So the one-size-fits-all approach, we heard about it yesterday from Andy already, the fact that antidepressants are effective, but not for all, but we still don't know for whom they work then. And it's really, we are applying treatments that are not directly targeting specific biological mechanisms that have been proven to be present in an individual specific patient. So that's maybe a little bit a depressing story, but I think it is good to be aware of these circumstances where we are coming from. But fortunately, I think there is also developments, and I think in the last 20 years, due to technological changes, due to technological implications of what we can do now in research, we have also learned a lot about the pathophysiology of depression. And this is a figure that is coming from a recent Nature Review Disease Primer paper, really showing both the central brain related processes, but also the peripheral processes that are involved in depression. And I will zoom in also, like Carmine, just a little bit more on the immune metabolic processes that we see in persons with depression. To just come back to one question that was asked also yesterday. So what is now the relevance that the involvement of the immune system is really causally involved in the presence of depressive symptomatology? I think there are quite several lines of research telling us that these are really etiologically relevant connections. Well, first of all, we know from people that, for instance, develop autoimmune or infectious diseases that later on they are more at risk to develop conditions like depression. We also know from experimental conditions that administrations of, for instance, certain vaccines that are boosting the immune system, that they yield sickness behaviors and symptoms that are really much overlapping with depressive symptomatology. We know from large multiple cohort-based studies that if you compare depressed people with non-depressed people, and as we just heard some examples from Carmine from the UK Biobank, for instance, which is one of the biggest studies out there, that depressed people have indeed significantly higher levels of inflammatory markers like CRP, but also IL-6 and TNF-alpha, for instance. And I think also we can learn from genetic studies, where we are now really scaling up the genetic studies in depression. There is a medical archive paper currently online where we are now having a huge genome-wide association study out there involving more than 4 million individuals, and where we now are at the stage where we have more than 650 genome-wide significant genetic variants that are linked to depression. And those, if we really examine those genetic pathways, then first of all, it's obviously clear that the genetic pathways that are involved in depression are directly genetic pathways really relevant for brain function. So I think this is really the story we need to keep in mind. There are sometimes people questioning, is depression even a brain disorder? I think the genetics tells us clearly yes. But I think the genetics also tells us clearly, yes, it's not just a brain disorder, because also if you look at genetic variants that are significantly linked to depression, there is a lot of inflammatory and metabolic genetic variants relevant coming out of GWAS studies, confirming that genetic vulnerability for immune metabolic processes is also a risk factor for development of depression. I do think that obviously inflammation and immune dysregulation is not standing alone. And I think in system biology, I think we really have lots of evidence that, for instance, a very strong interaction between lipid metabolism and inflammation takes place. And this really has impact in all kinds of peripheral tissues, as demonstrated here on this slide. Obviously in the brain, but not just only in the brain, also in the liver, in the pancreas, in the blood vessels, in the muscle. And that really links inflammation as a bodily system to all kinds of organ systems. And especially with the interaction with lipid metabolism at these different organ systems, this also explains why inflammation is not just relevant for brain inflammation, but also, for instance, links to diabetes development, links to atherosclerosis development. And that clearly, again, links depressive disorder to somatic conditions. And I think really that is key, that we should be realizing that. And we know also from depression studies that there is a very clear bidirectional interaction between depression and, for instance, insulin and leptin resistance. We know that metabolic syndrome dysregulations, obesity are much more prominently present in depressed people. And that is really, the question is, what is the chicken and the egg? I'm not sure whether that's the most relevant question, because I think we know that there is a vicious cycle going on between mental health and these somatic dysregulations. And I think, yes, it can start for some people maybe with mental health problems, and it can start with other people with metabolic immune dysregulations. And I think it's just a matter of breaking the cycle. And the question is how to best break that cycle. I'm going to show you a few slides from the NESTA project, and I put this slide up here because I do think that also cohort studies and connecting findings and working together between cohort studies is very relevant to move the field. I know Marion, we talked about that yesterday, about the idea to really start and intensify a cohort hub for psychiatric disorders, where we collaborate with individuals and investigators, having cohort data available to really harmonize more and learn and utilize each other's resources more, to really use the large sample sizes that we have available, but that we are not always linking nicely together yet. So what we have in the NESTA study is now more than 15 years of data collection in almost, 3,500 individuals. It's a cohort that is enriched for people with depression and anxiety, but we also have healthy controls. We have now 7 waves of data collection, and on 6 of these waves, we have biobanks. We have lots of freezers in Amsterdam UMC filled with blood samples with these patients, and we can do all kinds of omics with that data if we have the resources. I think one of the bigger questions that we did not get to this morning is, what is the difference between neurology and oncology versus psychiatry? I would say it's also the financial situations and the funds that we are lacking to really do the large scale steps that are sometimes going on in other fields. So if there are people interested in collaborating with us on really better using our biobank samples, I'm here. But I do think it's really important, because I think we can learn from these cohorts, I think, quite a lot. So one thing that we have done using the Nesta data and collaborating with some other Dutch cohorts that we have available in the Netherlands is really doing a large-scale metabolomics profile in relationship to depression. And this is a paper published in Biological Psychiatry a few years ago, where we now have more than 5,300 depressed cases and 9,200 controls, where we compare directly a metabolomics profile called the Nightingale platform, where we measured 51 metabolites and compared them between depressed and non-depressed people. And it's amazing to see that of these 51 metabolites, 25 are significantly different between people with depression and healthy controls. And these are very much zooming in on lipid dysregulation, but also glycoprotein, an inflammatory marker, is part of this platform and was significantly highly or much more highly had higher levels in people with depression than in non-depressed people. And in addition to that, there was really a shift towards less high-density lipoprotein and more very low lipoprotein particles in people with depression and higher triglyceride particles in people with depression. So this really shows that there is overall, if you look at these large numbers, a shift at the metabolomic level that is detectable at large scale and really consistently across studies. Also, if we look at immune system indications and involvement in depression from Nesta, at several levels, we do consistently show that people with depression, for instance, have higher levels of inflammatory markers. They have higher gene expression, like also Carmine already illustrated, higher gene expression of immune pathways in people with depression, and also, again, the genome-wide analysis point towards involvement of inflammation genes. But again, as Carmine mentioned, this is not happening for all people. And I think this is really essential for us to be zooming in on. We cannot and we should not make the mistake to assume that every depressed person has immune metabolic dysregulations. I think from looking at the effect sizes, we know that this is not going on because the effect sizes overall of associations are not huge. And we really need to look better at who are then the specific patients that do have these dysregulations. And I think that's really the essence of the precision psychiatry step that we are working on making. And I do think, again, large cohorts can be really useful for that. Why? Because we then have large groups of patients and we actually can dive into these patients and really look at who are the patients that have immune metabolic dysregulations. And that's exactly what we are trying to do in the Nesta project. We look at symptomatology, we look at risk factors, we look at cores, we look at pathophysiology, and we look at genes to really see, are there certain homogeneous subgroups that we can identify that really have much more indication of a certain pathophysiological dysregulation. And when we do that, and seems like a very simple picture, but I can tell you this is 20 years of work. And I see Femke sitting there smiling. So Femke Juri Milaneschi, who actually cannot be here because he is attending an Ernst Stringman forum at the moment, focusing on metabolic psychiatry. So he is there. Yeah, we in our group have been really working on can we see the subgroups of patients that do have immunometabolic depression, and this is what we are arriving at in various papers looking at. So we do see that people with immune metabolic depression, as we start to call it, which is about 25 to 30% of our Nesta cohort, if we zoom in on people with current depressive disorder. These people are not having all kinds of symptoms. They seem to be scoring higher on certain more atypical energy-related symptomatology. They are the ones, if you just think about the DSM criteria, the DSM criteria is really merging quite strange and different and opposite symptoms together in one group of diagnosis. Some depressed patients have hypersomnia. Other depressed patients have insomnia. It doesn't matter for your diagnosis, but I think it does matter for the pathophysiology that is underlying, because it's completely ridiculous to believe that people with opposite ends of a symptom dimension have the same underlying pathophysiology. And the same is true for appetite and weight regulation, or for psychomotor retardation or agitation. And in a lot of scorings that we do, in a lot of instruments that we have been using for decades in psychiatry, we are just measuring sleep problems. We don't even care about whether it is people sleeping all the day or people waking up and not being able to sleep. And obviously that is a completely different feature. So I think we also need to do a better job in profiling the symptoms that we are measuring, because I think we are losing some details that I think could be turning out to be really relevant. And I think that's what we are seeing, because the people with immunometabolic depression are the ones who have more appetite and weight. They have lead-in paralysis, they have fatigue, and they have hypersomnia. This in contrast to other people that are as severely depressed, that are as disabled, that have as much comorbid anxiety, for instance. So these two groups don't differ in severity, they only differ in the types of symptoms that they're having. So the more typical depressed group actually is the group that shows less appetite weight, that shows more insomnia, and shows highest ratings of suicidal ideation. Then also, if you look at course and pathophysiology, that's where the differences emerge. We find in people with the more atypical energy-related depressive symptoms, we find more inflammation. We find that that is the group with dyslipidemia, with leptin and insulin resistance. And we have actually proven that in various studies now, also utilizing the Psychiatric Genomics Consortium data and the UK Biobank data, that that is actually the symptom profile that is much more stronger linked to the genetic vulnerability for weight and immunometabolic dysregulation. This in contrast to the other group of about 60 to 70% of the depressed population that actually shows some other features that actually is more strongly linked to the genetic vulnerability for other psychiatric conditions such as schizophrenia. And that's actually, and that's something that we probably should explore a little bit more also, but that's actually where we do see higher reportings of life events, childhood trauma, and hyperactivation of the HPA axis. But just zooming in on immunometabolic depression, so the clustering that we are seeing is a clustering of symptoms and a clustering of pathophysiology driven by, again, leptin resistance, insulin resistance, and pro-inflammatory state and dyslipidemia. So how is this relevant for clinical care? I think it really is relevant. And if you ask me the question, what are actually the impacts of our current treatments that we have? And the current antidepressants is by far the most currently used treatments that we provide to patients. What are the current antidepressants doing on immune metabolic health? I think if I ask that to 4 or 5 people here in the audience, I think I would get completely different answers, because I think we're just not able to address that question very well. There have been some studies looked at that, but that's really small number of studies, first of all. They have looked at all kinds of different antidepressants, so we do not have really the comprehensive picture. And if you then look at the results, it's going on in all kinds of directions. For CRP, I think there is some evidence that antidepressants actually increase CRP levels when people start using it, and this is coming from RCT data. For TNF-alpha, it goes the other way around. No, for IL-6, it goes the other way around. For TNF-alpha, it's kind of in the middle. But I think this is also a really relevant question that we haven't dealt with, because it could also be that certain antidepressants are more beneficial in restoring immune metabolic health than others, and we don't have the answer to that question yet. For weight, we know, I think, a little bit more, because weight increase is being examined a little bit more than immune metabolic impacts of our medications. And for weight, I think the picture is quite diverse, and that really tells us that certain medications are reducing weight and other medications are increasing weight. But again, I think the immunometabolic impact of our current medication is something that we're not even monitoring and not even incorporating in clinical practice. Then another question is immunometabolic stress, is the presence of immunometabolic stress in depressed patients, does it impact on antidepressant response? And I think this is also a little bit what Carmine was getting at. And we talked about that yesterday also. But the problem is, do we have lots of data to address that question? So we tried, and this is work led by PhD student Sarah Freiling that was just published this year. We examined in 4 large-scale antidepressant treatment studies, the iSpot, the COMET, the GenDep, and the EMBARK study. I also see here in the audience. We measured in those 4 trials, do people, depressed people that have at baseline more features of immunometabolic depression, and that could be either atypical energy-related symptoms, high BMI, high CRP, or their combination, and does that predict poor response to antidepressant treatments? The overall result is yes, but really to a very modest extent. But it does indicate maybe a little bit that immunometabolic stress is in the way of a response to antidepressant treatments. Not so strongly that I think we should now can implement this knowledge now already and tell certain people that they should not be using antidepressants, for instance. Then just 2 more slides on anti-inflammatory treatment. You heard already Carmine talking about that and Andy talking about that yesterday. So yes, we do have some first hopeful evidence coming from meta-analysis showing that anti-inflammatory treatment may improve depressive symptomatology over time. But this is majorly coming from the fields besides or outside of psychiatry. Lots of these studies in these meta-analysis are actually focusing on rheumatoid arthritis patients where they are treating people with anti-inflammatory treatment, and then they accidentally have measured depressive symptomatology scores on the side. But that's obviously not the psychiatric populations that necessarily we are talking about. And then 2 slides just summarizing also the findings that Carmine already showed, that there are now also in anti-inflammatory studies where we are targeting depressed patients. And if you look at both these studies that have been presented before, if you are not stratifying anything, we do not find an effect of anti-inflammatory treatment. But then, you know, we shared this morning said, duh, why would you treat inflammation if there is not even inflammation to start with, right? And this is where we really are coming from as well. We have done several of these anti-inflammatory medication interventions in non-stratified samples, in people that do not even, were not even tested on the presence of inflammation to begin with. And I think this is really something where, we need a change. One of the things that our group, and again, Femke Lamers, Juri Milaneschi, and Joël Sweep are leading this RCT, is an RCT where we in Amsterdam are recruiting people and randomize them to celecoxib versus placebo. But now this trial is not recruiting all depressed patients. We are now really doing a targeted recruitment. We only include people that have evidence of what we believe is essential in immunometabolic dysregulation, and that is having high score of atypical energy-related symptoms, plus high evidence of at least some systematic inflammation to start with. So this makes recruitment for trials much more difficult, because actually you need to recruit lots of people, and then 2/3 of those people cannot participate. But I think this is where we need to be going at if we really want to zoom in and do a targeted intervention starting from a biological. People with immunometabolic dysregulation, and then also have better conclusions about how useful it is to provide specific interventions to that subgroup of people. We also need to learn whether the anti-inflammatory targeting is indeed the right one, and obviously we can much more refine the processes underlying our anti-inflammatory targeting. To just, I have a slightly different version of the Aspire slide, and I didn't have time to put the new logo on yet, but this I think is really something that we should be doing in trial, in the trial fields. But I think we should also do that in the cohort fields, because I think also the cohorts and the trials are both necessary to learn us more about what are then the subgroups of patients with certain biological underlying mechanisms that we should start targeting. I do want to end with 3 slides where I just talk about lifestyle, because I do believe that especially for immunometabolic dysregulation, we know it's not just our body that is or our genes that are driving dysregulations. I think we know massively that people with depression are having very unhealthy lifestyles, and lifestyles do impact largely on immunometabolic dysregulation. We are not very often targeting this in a systematic way, and I think I'm really a little bit sad about how far we are in implementing lifestyle interventions in clinical care, because I think we are really not far at all. And this is despite the fact that I think lots of lines of research are telling us that this is massively important. So a BMJ paper just a few weeks ago convincingly showing that exercise interventions at least are as effective as antidepressants or CBT treatment for people with depression. I think here also the question is for whom, and I don't say that exercise intervention works for everybody. I think it's actually the same issue there as it is for antidepressants and cognitive behavioral treatment. But I do think it is an alternative intervention that can really benefit our patients, and we need to pay more attention to it, especially because we know that exercise and physical activity is doing a lot to immunometabolic health. There is convincing evidence that people that are participating in exercise intervention over time, I mean, the acute effects of exercise can be an increase in inflammation, but over time, when people are sustaining that behavior, it reduces an inflammation state. And it also has very many beneficial effects on other metabolic syndrome components, for instance. So just to end with 2 slides on a local study that we did, where we took depressed patients and either let them participate in running therapy 16 weeks, or let them have an SSRI treatment for 16 weeks. And the overall depressive severity scores over time, they improved slightly though. I mean, it's not, these are not magic treatments, but people after 16 weeks did improve in overall. But they did improve in a similar way. So again, showing that I think running therapy could be an alternative intervention that we should be providing to patients more than we are currently doing. So no significant difference in terms of symptomatology. But what happens if you look at immunometabolic outcomes over time? And this is again 16-week data, so really short, and it's really not a massively large study at all. 96 people in the running therapy group and 45 people in the antidepressant group. But despite that, and despite the fact that immunometabolic health was one of our primary endpoints, because we really wanted to look at not just only mental health outcomes, and we were quite surprised to already see significant differences with this rather small sample size, where we do see that people that started antidepressants actually increased their weight, increased weight circumference, increased triglyceride levels, and had an increase in C-reactive protein, which is in line, I think, with the meta-analysis I showed earlier, that some antidepressants can really increase inflammation state. And if you look at the running therapy group, they actually showed the opposite direction of change. So they went down in some of these outcomes. If you then do a per protocol analysis where you only look at people that really followed the intervention as we planned it, and then you do see less compliance in a running therapy group. So yes, it is not very easy to get people with depression motivated to participate in a running therapy. You will have failures, but at least there were quite a sustainable group that really continued running for 16 weeks. And if you then look at that per protocol analysis, then you even see larger differences between the two groups. So really, I think we really should be thinking about breaking the cycle in several ways. And that can be, yes, partly through anti-inflammatory medication, but maybe also through alternative interventions like lifestyle. And I could have spent more time on nutrition, but I'm not going to do that because of the end of my talk. So I want to give some take-home messages. I think immunometabolic stress, as I've shown you, is more prevalent in people with depression and can contribute to increased somatic comorbidity and antidepressant non-response. But we should be aware that this is not present in all patients, that we need to better understand who are the ones at risk and how can we identify them in the best way. And then obviously we need to test our specific interventions that are targeting immunometabolic stress, anti-inflammatories, but also lifestyle regimen, if you would ask me. So thank you very much. And I'm looking forward to the next talk.
Thank you very much, Brenda, for again showing that we can move from inspiration to implementation, and also along the line of precision psychiatry.